just see from the map the distribution, and the only country in Africa that has more than 300,000 cases is South Africa, and we are more below the 300,000 cases. And then when we look at the graph.
Is any your
Yes.
slide, if you can just maybe go to slideshow.
Yeah, it's not showing slideshow.
Okay, if you look at the top, if you go to your top bar, it shows you slideshow, then just click on that. So you have to remove the protective view, just start there and enable editing, and then it will be able to move on. Thank you.
Is this okay now?
If you can go, if you go to slideshow, we will be able to see it bigger, so then it will be easier to read.
My screen is showing that it's on slideshow.
Okay.
Isn't it? We want you to have the full screen, So click on enable editing. Click on enable editing.
Okay.
Up there, enable editing.
Okay. Let's try again.
Then click on the full.
Is it full now?
Well, better. Yes, better.
Okay, great. Okay, sorry about that. So I'm very sorry about that. So just quickly move, like I was talking about here, from the WHO data and by regions, we could see that most of the cases are coming from the Americas, and we can also see that Europe now has the cases are also spiking again in Europe, and Africa has the least cases, represented by the red color in the graph. Then when we come down to Africa, our figures stand at 1.7 million cases as at this morning, and 41,000 people have died. And in Africa, CFR is 2.7%. And on a positive note, we have about 82% recoveries. So when we look closely, we can see that we have had spiked at around July, but we are also, cases came down, and then it seems that the cases are also climbing up again. And you can also see the distribution that the southern region has reported most of the cases, followed by the northern, and then we can have the other regions. And this can be better seen on this table, where we have separated the number of cases, deaths, and recoveries according to the regions. So the northern actually has the highest CFR, but the highest number of cases are in the southern region, and that's really, with South Africa contributing a lot of those cases. And that's followed by the northern region, the western region, the eastern, and then the central. And also the western has the lowest CFR on the continent. So this is just looking at cases by number of cases each country has had, and we only have one country on the continent with more than 500,000 cases, which is South Africa, and about 7 countries have between 50 to 500,000 cases. And most of the countries, which is about 23 of them, have less than 5,000 cases. Then we just look at incidence, which is number of cases per 100,000 population. And we have 5 countries that fall into the less than 10 cases by 100,000 population. Majority of the countries fall within 10 and 100 cases in 100,000 population. And only 5 countries have more than 500 cases per 100,000 population. So this is just looking at the cumulative number of tests conducted on the continent from the beginning of the pandemic till now. And we have more than 80 million tests conducted, and we can see how it varies according to the region, with southern leading, followed by northern, eastern, western, and then central. cumulative cases in total, and we have on the continent a 9.6% positivity rate. So I'm just going to take us through quickly the guidelines that the IPC Technical Working Group of the African Task Force for Coronavirus has provided. We had earlier in the pandemic developed a guideline for community use of face masks, and we have also done a review of this, looking at new evidence as to what's the new things that we know now about the effectiveness of using face masks in the community. So the guideline just sort of advises us on the sort of masks to use in what circumstance, and it also gives the proof that masks can actually reduce transmission from the wearer, so we can stop the transmission from the source. And it also explains the concept of asymptomatic transmission and how masks can help reduce it. So even if you're not showing symptoms, using a face mask can help you not to spread it to the other people. So these are all found on our website, africacdc.org, where you have resources. We can get these documents. Another document we looked at was on the use of personal protective equipment for different clinical settings and activities. Of course, a lot has been said about this, but we felt it was important for us to contextualize the global guidance for African setting, what is practicable in our continent, in our facilities. So it just references the evidence for the best PPE to use to protect yourself from COVID-19 as you're treating and seeing to patients. So we also have a simple checklist and some relevant standards to help with procurement and supply. Then another one we looked at, we worked on was the TPTAP guidance, where it's sort of a very simple yet effective contraption that helps for us to have hand washing facilities even in the most resource limited setting. So it gives you steps on how to actually construct the tippy tap. You just have wood, water, a bar of soap and string, and you can actually have a hand washing station wherever you are. The good thing is that this can be done anywhere. Then we have another one on environmental decontamination. We know how COVID is spread, and it's important that cleaning and disinfection is taken very serious. So it looks at general principles of cleaning, looks at advices on healthcare and non-healthcare setting. So, and also brings down the global guidance to the African setting. Another one is on setting up isolation ward for COVID-19 cases. So we looked at how to set up isolation centers, looking at minimum requirements, looking at the facility designs that will optimize and make sure that infection prevention control measures are actually put into consideration in these centers. So it's quite practical. It has pictures, it has step-by-step guides for you to use. And then also looking at COVID-19 being now in the community, it's no longer, it's all over. And we have contact tracers working in the community to help identify cases. We developed a guideline on infection prevention among these contact tracers to make sure that they are protected while they're doing their job. So it involves administrative controls, environmental controls, use of PPE, how to don and how to dispose of them. Then another document we also looked at is managing acute strategies of PPEs during the pandemic. And this, we all know that PPEs are not enough. We are constantly running out. So it gives some consideration and some options that we can use in our countries to manage shortages. It also gives examples on how to optimize the use of PPE, some contingency plannings, and also decontamination of some reusable PPEs. Then we know we've had a series of webinars, and this is series 5. And so from the first 3 series we looked at the frequently asked questions that people like you who have been on this webinar webinars have asked, and we compiled this into a document. So it covers screening, face masks, PPE, environmental cleaning, isolation facilities, healthcare workers, and community. So you can look at these, and some of the questions that you keep asking have already been answered in this document, and they are very practical answers that have been given. So coming soon, we are currently working on a document on managing family caregivers and visitors at healthcare facilities. As we know, airlines and offices are opening up. We're working on a document to address IPC measures in these places, guidance on primary healthcare settings, guidance on ambulances. We're also looking at the quality of care 95 masks, and we are also working on a mask playbook that gathers all the evidence to promote the use of face masks. And finally, the use of leisure centers like swimming pools and gyms in COVID-19 settings. So we see we're moving towards economies opening, places opening, and also providing guidelines that can help us be protected as we're all opening up. So thank you very much, and that's all from me. So you can also access all this information at our website, africacdc.org/COVID-19 resources. Thank you very much. Back to you, Anna.
Thank you very much. Great to have this, and I think there's a lot of resources available for everybody that's willing to just go and have a look. Thank you very much for all the hard work. It's also now my privilege to introduce you to Ms. Sakai Al-Rubahai. She's an ICANN member and also an ICAS member, and ICAS is the Infection Control Society in Zimbabwe, which is affiliated with ICANN. Ms. Sakai is also a PDIC or postgraduate diploma in infection control from Busa University in Zimbabwe, and she's also done midwifery and general nursing. So she's going to talk to us today on the review of the IPC and behavior change strategies that they've seen in Zimbabwe. Over to you, Sakai. Thank you.
A very good afternoon to you, everyone. Thank you all for joining so that you can also hear our experience, our IPC experience as Mpilo Central Hospital. I hope everyone can see my screen, Anna.
Yes, it's great. Thank you.
All right, thank you. So my topic today is COVID-19 positive healthcare workers, a review of infection prevention and control and behavior change strategies implemented at Mpilo Central Hospital. So outline of the presentation, I'm going to give an introduction of our hospital, and also we're going to discuss the COVID-19 positive staff statistics and IPC behavior change strategies, the outcomes, and also the challenges we are facing as a hospital. So as an introduction, Mpilo Central Hospital is a group of 4 hospitals, that is a pediatric hospital, a maternity hospital, general hospital. We also have got an opportunistic infectious hospital, it caters for all patients, all ages, with medical, surgical, and also gynecological. It is a referral center in the southern region of Africa for cancer patients where radiation, radiotherapy, and chemotherapy is offered. And it's also a training school for general nurses and midwives. And staff establishment is 1,744. The bed capacity is 1,000. That's Mpilo Central Hospital. So the hospital positive case, hospital COVID-19 cases information. So the institution recorded its first cases on the 28th of May 2020. And the 3 cases included a midwife who was working in labor ward, and the patient who was in an orthopedic ward, and also a patient in a gynecological ward. So these were our first 3 cases. So what was the general response in the hospital? So the nurses who were in contact with these 3 cases immediately went into quarantine at their homes. And as the rapid response team, which was already there, started strengthening our IPC measures, that is administratively, and also our environmental measures, and also our personal protective equipment. And the patients who were diagnosed with COVID-19 were discharged home. These patients were stable when they were screened for COVID-19. They were stable. So upon getting that COVID-19 diagnosis, they were discharged home for isolation at home. And then we also have a rapid response team for our city here, which is responsible for contact tracing outside the hospital and also doing the PCR testings in the community. And then they started visiting those who had tested positive to COVID-19, and they were reviewing their home environments. And for those who tested positive, they were sent to isolation center, which is Elangeni, for quarantine, for isolation there. So these are our statistics there from May, when we had our first healthcare worker. In May, we had one case, which was the midwife, who was who got the results on the 28th of May. And then in June, the cases rose to 51. In July, we had 113 cases who tested positive for COVID-19. In August, the cases started going down. We had 14 healthcare workers who were tested COVID positive. And then in September, we had 2 cases who tested positive. And so far in this month, as of today, we don't have any healthcare worker who has tested positive for COVID-19. So the recovery, 99.4% are recovered. And we had 1 death in August of a general nurse, but she also had existing comorbidities. So she's the only one who succumbed to COVID-19 in the hospital. So the statistics by job description, we had 41.4% of the 181 cases were nurses, and then 3.8% were doctors, 6% general hands, 36.4% were students, student nurses, and also student midwives, and also 6.6% was our pharmacy staff, and we also had our 0.5% was the staff from lab, and also had our clerks constituted 2.7% of the statistics. And we also had counselors, 1.6%, and also have with a security personnel who was also a part of the statistics. So the data being reported is from 181 healthcare workers, of which for the larger percentage is of nurses, whereas 36.4% were students and from School of Nursing and School of Midwifery. The doctors only constituted 3.8%, and the majority of the infected cases came from a maternity department and our OI clinic, which caters for HIV services. So generally, the rise of the nurses was just the rise. The cases of the nurses is drastically higher compared to any other healthcare worker. I think this is mainly because the nurses have more patient contact time than the doctors or any other personnel. And also the infection rate for clinical healthcare workers is generally higher than that of non-clinical healthcare workers. So when we're now doing our analysis, we found out that the possible causes for the rise in the cases was insufficient personal protective equipment, poor hand hygiene habits, long working hours, direct patient contact, also asymptomatic transmission, and reduced immunity. So generally, insufficient personal protective equipment is a domestic as well as a global problem. That's putting healthcare workers and patients at risk of contracting the COVID-19 while caring for the patients. And also this has forced healthcare facilities to implement policies for PPE distribution, and then healthcare workers use what is provided at that time. So due to insufficiency, the distribution in the different departments is quite low, what is required. Then also for poor hand hygiene, there were challenges identified at that time. The challenges were poor awareness of hand hygiene, the proper way of doing the hand hygiene, and also lack of availability of alcohol-based hand rub, and also infrastructural deficit, that is the non-functional sinks, which led to poor hand hygiene. And also for long working hours, the nurses were working for longer hours per day than any other healthcare worker, hence the increased risk. And also direct contact when looking after the patients and doing different procedures on the patients, wearing masks, not wearing masks. Initially, wearing of masks was not mandatory. So that put our nurses at higher risk. And then healthcare workers tend to be comfortable around each other, like in their the tea rooms and when they are going home. And generally there's reduced precautionary measures in the duty rooms and staff transport. And that's how some of our healthcare workers also got infected. And also for reduced immunity, I think due to the economic hardships, there's reduced immunity because people cannot afford a well-balanced diet. And there are a lot of stressors and also chronic conditions which lowers the immunity. Hence the rise in cases. These are some of the reasons that we identified that led to the possible rise in the cases. So for strengthening our IPC activities, we had to make use of interventions guided by the IPC hierarchy of controls, that is the administrative controls. We also put in place environmental controls and also use of PPE. Our rapid response team had to quickly act when the cases started rising to strengthen IPC. So as to reduce the morbidity and potential mortality and maintain health system capacity, and also to reduce secondary transmission within our facility. So we also made use of the WHO hand hygiene multimodal strategies to intervene to this rise in cases. So for these multi-modal strategies, we adopted so as to implement an integrated way to guide actions and provide a clear forecast for the implementers. So we looked at the systems change, also the training and education of healthcare workers, evaluation and feedback, and we were to put reminders in the workplace for healthcare workers as well as patients and visitors, so that they can be reminded on things like the signs and symptoms, what they are supposed to do if they suspect they have the infection, and also the general hand hygiene posters to remind each and everyone on the 6 steps and when you are supposed to perform hand hygiene. And also we also looked at institutional safety climate. So for administrative interventions, we started by doing a risk analysis, and we saw that a lot of people were visiting the hospital. So we had to reduce the number of visitors per patient to 1, and we also had to reduce the visiting time to only once per day. And also we had to do surveillance. Our infection control department had to do surveillance and report every day on any cases who are suspected to be having COVID, and a proper follow-up was being done and testing of all those potential cases. And also our risk communication, we strengthened it, communicating with everyone, the patients, and also the community around us, and all the personnel, all the different cadres who are employed at the hospital. And we also started putting a signage in different areas for communicating. And then training was done for all healthcare personnel, and that included from the standard precautions in relation to COVID-19. We also trained on transmission-based precautions. We trained on case management, waste management, linen management, equipment decontamination, also environmental cleaning. And then for the suspected sources, we're doing rapid triaging so that we identify them quickly. Tents were set up at the main gates where everyone who was coming into the hospital was screened. They were making a screening by using the infrared thermometers, and there was also a questionnaire. There's also a questionnaire which is used to ask general questions which can help us to identify the suspects. And also we have come up with an isolation unit which we refer to as people under investigation at our hospital, where all the suspects are admitted, and then upon receiving their results, if they are positive, we send them to a hospital which has been dedicated for COVID positive patients. And if they are negative, then they will be admitted in the other general wards for further management of their ailments. And then there's also dedicated staff to that people under investigation ward, and they are provided with the required personal protective equipment so as to manage the patients there. And then for the environmental controls, we taught everyone, and we strengthened our IPC on contact and droplet precautions, and also patient placement. We are making sure that our patients that are properly spaced at least 1.5 meters in between them. And also in our patient waiting areas, we've put social distance markings to try and make sure that everyone is at least a meter apart from the next patient. And for ventilation, we always make sure that our windows are well ventilated. And for those other smaller rooms, we've avoided using them where ventilation is not proper. And then for cleaning, we have our checklists, which we've put in the several departments, which we are using when we are checking for our general cleanliness. And these are known to even our general hands, and they're also signing, then putting their signatures after cleaning. And we've also strengthened supervision in the different departments. And then we also strengthened our waste management. We are from the point of generation, the segregation, even our transporting to incineration, and we are making sure that it's incinerated, it's not staying long there, and it's incinerated on time. Also, then personal protective equipment, we've received a lot of donations from well-wishers, and the hospital is also buying personal protective equipment guided by the guidelines from WHO and CDC. And also our country has come up with, we've come up with our own guidelines, which we adopted from CDC and WHO, which we are also making use of as a hospital. So we've got N95 surgical mask, gloves, we've got shoes, we also have got coveralls and disposable gowns and aprons. Also, we have a lot of alcohol-based hand rub, and we've come up with a lot of donning and doffing posters so that people may be guided appropriately. So IPC behavior change in COVID-19. Generally, IPC behavior change is of great significance, which could help guide the evidence-based optional IPC behaviors to combat future large-scale outbreaks. Then, despite the importance of IPC in COVID-19, compliance to IPC guidance before the diagnosis of the initial cases was really suboptimal in our hospital. The IPC program has been there for a very long time now, but compliance generally was suboptimal. So now, as more and more healthcare workers got infected and the trainings were then conducted, there's a significant difference in behavior and adherence to protective and preventive measures was observed, and it helped in protecting healthcare workers from contamination and prevention of disease transmission, as shown by the decline in cases during the 5-month period that I just reported. And then healthcare workers from a higher risk department, that is our people under investigations, the OI clinic, and also our lab departments, we notice that they've got a better practice in most IPC behavior, especially the people under investigations. This is a ward which is dedicated to COVID suspects and COVID positive patients. So the donning and the doffing, which is being done there, is better, and also the hand hygiene practice. They are aware of the great, because it's better because they are aware of the great risk that they are in, and also in some areas there are waste behaviors that are being shown especially in areas that have got a higher workload and insufficient supply of resources, and hand hygiene opportunities generally, they are being missed in those departments like labor ward and casualty due to higher workload and use of gloves. At times, the people make the use of gloves, it overrides the opportunities for hand hygiene. And also, we've noted that environmental cleaning is not being done as guided due to increased traffic and lack of human resources in especially labor and our casualty. But the other departments, they are doing very well. And also noted was that general preparedness in the different departments and years of experience of some cadres in services influenced greatly in behavior change. For instance, at our lab and our radiotherapy clinic and also our pediatric hospital, they've prepared themselves for the COVID cases. They've prepared in terms of IPC. So they've hand hygiene stations. Even their screening, their entry points there is being done very well. And also we've noted that some senior nurses and doctors seem to understand better the importance of IPC, and their actions are constant with guidelines. So usually these are our role models in terms of implementing IPC, good IPC behaviors. So we also adopted the multimodal strategies, and our hand hygiene compliance, we used the observation tool. We did a baseline observations in June, and the compliance rate was around 51%. And then around August, we did another post-intervention observation using the observation tool, and the hand hygiene practices overall, they are satisfactory, especially after body fluid exposures and before procedures. We looked at the before body fluid exposures and after body fluid, before aseptic technique procedures, and we calculated the compliance rate, and it was 69%. And then hand hygiene before touching a patient and after patient surroundings is still very low, which hinders the prevention, which hinders the controlling of the prevention of COVID-19. The compliance rate is around 54%. And then generally the availability of alcohol-based hand rub is satisfactory. The hospital is providing, and also a lot of donors are coming in to help us with the alcohol-based hand rub. And then for patient placement, we've placed some social distance markings in patient waiting areas, like I said, to try and control the flow of patients there. And then for use of personal protective equipment, soon after realizing the initial cases, healthcare workers started demanding personal protective equipment due to panic, like the coveralls, the N95, the shields, and a lot of people were double gloving. This was due to just that people were scared that they would contract the COVID-19. So after the trainings now, the majority complied to the guidelines that were provided on use of personal protective equipment. And also compliance of mask and glove use is high all around the hospital. And use of personal protective equipment like the goggles, the face shields is satisfactory where it's supposed to be used, as people are complaining with the material, such as becoming foggy and reducing their visual acuity. So these are some pictures which are just showing some of our hand hygiene stations and the sanitizers there. The other one at the far right is outside. And this also picture is also showing one of the trainings that was conducted for the healthcare personnel. And those are the social distance markings in the waiting areas, and some information on the walls for the patients to read and get more information on how they can protect themselves. So the general outcomes on the behavior change, there was a strict strengthening of standardized preventive measures and protective measures. There was improved staff safety and reduced staff infections since we started implementing. We've been implementing, but we had to strengthen now when we were hit by COVID. So we saw this reduction of the staff cases when we started implementing, and also a reduction of transmission of COVID-19 within the hospital and the communities, and the reduced purchasing of personal protective equipment, because now healthcare workers were using it as required according to guidelines. And then there was also an increased nurse patient ratio as nurses were no longer going for isolation or quarantine because they are not infected anymore. And then we've got the challenges that we are facing despite all the interventions that we have attempted to put in place. Like for personal protective equipment, it's still limited, like elaborated by the first speaker. And we are working at 12-hour shifts. Some shifts are 12-hour shifts, and people are, the nurses and any other personnel, they are using one mask throughout the 12 hours due to the shortages. And also there are a few people who were not trained. We really tried to train everyone within the institution, but there were some who were left out, and some who haven't really changed their behavior despite having the role models in place, or despite having the knowledge. There are some who still wear two products simultaneously, like the gloves and also the masks. And the other challenge you are having is the N95. People are not doing the fit testing, and mostly, even if we want to do it, we are only supplied with one size of the mask. So even if you fit test it and it's not the proper size for you, we go on to use that, because that is what is available. And also we have a delay in getting our COVID results. We can go for up to 4 or 5 days without receiving the results, because the results are being done at the National TB Reference Lab, which is based at Impilo, but it's the only one a government institution and this in our city, in our province, who is doing these tests. They are for free, so we tend to have they tend to have a work overload, hence the delay in producing the results. So in conclusion, so generally, healthcare personnel were equipped with necessary knowledge, the skills and abilities to implement effective IPC practices. And there was generally an increase in the knowledge base and provision of required resources. And this influenced the perception and motivated the healthcare workers to change behavior in our institution. And also the use of IPC link nurses to build peer-to-peer role models and champions had positive influence on implementation of key IPC practices. So ICAS also trained link nurses in all the hospitals. So we really make use of those link nurses as role models in their departments. And so I would like to thank the hospital executive for approving my presentation. And I also want to thank the Ministry of Health and Child Care, and also the Nursing Directorate and non-governmental organizations who supported and funded all the trainings. And I also want to thank Africa CDC, IPC and ICANN for the opportunity to share our experience with the world. Thank you.
Thank you very much, Sakai. We will take all the questions at the end. There is some questions and answers in the question and answer box. I want to introduce our next speaker, who's going to talk to us about the perspective from Lesotho. Dr. Limpu Mali, I'm sorry if I pronounce your surname incorrectly. You are the National IPC Focal Person in Lesotho. Over to you, Dr. Limpu.
Thank you. Can you see my screen?
Yes, I can see your screen as well then. Thank you.
Okay, thank you. Thank you for the opportunity of sharing our experiences in Lesotho. The outline of the presentation will be the country profile, health facilities and healthcare workers in Lesotho, IPC structure for the national up to the facility level, capacity building, and implementation of the KPI scorecard, and healthcare worker infections and key achievements in IPC, and the next steps in implementation of the program. Lesotho has a population of 2+ million, and to date, we have a test conducted at 21,103 tests. We have a total number of confirmed cases as 1,822, and we have had 42 deaths to date. We have 2 COVID isolation facilities and 2 main testing centers. One is the National Reference Lab and a private laboratory. We have a coordination body for coordinating all the activities of COVID-19 through the National COVID-19 Secretariat. When we look at the timeline of the events, Lesotho had the first case in May 2020, and we began to have a community transmission and the first death between June and July 2020. We have 244 healthcare facilities, and 218 of these are primary healthcare facilities, 17 general hospitals, and 2 specialized hospitals, and 1 private hospital, and we have 1 tertiary level referral hospital. The total number of healthcare workers in Lesotho is 35,347, and 20,412 of these healthcare workers work within the public sector, and the rest work within the private sector. And we have a complement of 216 healthcare workers who are expatriates. We have the IPC, in terms of the IPC structure from the national level to the facility level. Before COVID, our IPC program was mainly functional within the TB program. And during COVID, we are in a process of revamping and building up the IPC program and setting up the structures at all levels from national to the facility level. We have revised the IPC guidelines based on WHO and CDC guidance, and we are in the process of identifying IPC focal points for at national level, district, and also at facility level. And we are resuscitating the IPC committees at all these 3 levels. Trainings have been, we did trainings before, during the preparedness period in all the 10 districts prior to us having a COVID case identified. Currently, we have trained 1,346 healthcare workers in all the 10 districts. This picture just shows when we had the first IPC facility-based training, and also there was a demonstration of donning and doffing of PPE. In terms of the proportion of health facilities with at least one healthcare worker trained on IPC, these are the percentages of healthcare workers. The districts of Berea and Mafeteng have most number of facilities trained, because these are the 2 districts where our 2 isolation facilities are based on. As you can see, we still have to increase the number of trays, or to cascade our trainings to all the districts, so that our coverage of facilities with at least one person trained on IPC for COVID can be increased. As part of the capacity building, we have also, on IPC, we have also developed and printed IC materials for IPC, and also some that were used for the communities and for the institutions outside the health facilities. So far, we have had 217 healthcare workers that are infected, and Maseru, which is the capital city, has the highest number of healthcare workers that are infected. And this is the same district where we also lost life of 2 healthcare workers. We have experienced 3 healthcare workers that have died in the country. Based on this scenario, we actually implemented the Afro KPI and scorecard, which we had planned that we were going to do it in July, but we had challenges of putting up the team together because of time and logistics, and the assessment feedback to the facilities didn't occur at the time that we had planned. And as a result, the implementation of the recommendations at the facility level is significantly delayed. But this week, we are finalizing, giving feedback to the facilities that had been assessed. The achievements that we had with the KPI scorecard is that we were able to subject this to all the hospitals in the country, including the referral hospital. And the findings of the assessment have also been shared with the Ministry of Health and with the National COVID Secretariat. And it has also been shared with all partners and stakeholders in the country. And the assessment to the facilities is ongoing. And we are now going to work with the facilities to develop IPC improvement plans to address the challenges that we identified through the scorecard. And these are the results of the KPI scorecard in all the facilities that were assessed as a baseline. And as you can see, 50% of our facilities are scored below 50%, which means that these facilities, we need to develop improvement plans with them. And these facilities that scored below 50%, we have to follow them up on a daily basis. And most of our other hospitals scored average, which was between 50 to 75. And this need to be followed up at least 3 times a week. We only had one facility, which is our National Referral Hospital, which scored with an adequate score of 81%. So when we look at all the hospitals in the country, our average score is at 50%, which means we still have to do a lot of training and a lot of weaknesses were in areas of donning and doffing of PPE. And also there were still issues even with hand hygiene. There were also issues mainly with surveillance and risk assessment of the healthcare workers in the facilities. And what do we do also when our healthcare workers are infected? It was only one hospital which had a clear plan of what to do in case they have healthcare workers that are infected. The key achievements that we have up to date on infection and prevention and control and WASH is that we have a 3-month IPC operational plan that has been developed. And we have developed guiding documents for healthcare workers and also for non-healthcare facilities. This includes a guidance for school reopening, a guidance for environmental cleaning for non-healthcare facilities, and also for the sporting fraternity and many other institutions. And IPC trainings have been conducted in all 10 districts, even though we still need to support the districts to do step-down training so that all facilities have IPC focal points that are trained. We have done orientation on the use of the different IPC tools to all the districts. And as I had indicated earlier, we did assessment using the WHO KPI scorecard tool. We have also adopted the healthcare worker infections WHO tools, and these are currently being shared with the districts so that we can implement them and also identify risks of healthcare workers. We still need to do in-depth analysis of our healthcare workers who are infected to identify whether they have been infected within the health facilities or they've been infected at the community level. We are also ensuring infection and prevention control measures at points of entry. Currently, we have 5 of our borders that are opened. And way forward, we are in a process of establishing a functional IPC program at facility level. And we are currently disseminating IPC guiding tools to all the facilities, and we'll continue ongoing supportive supervision and mentorship to build on the training that has been conducted in some facilities. And also we are going to do provision of assessment and management protocols for healthcare workers exposed or confirmed. Then this needs to be clearly defined, and we need to have a team for investigation. We are also going to encourage and monitor adherence of IPC best practices as per the guidelines, because when we started when having the first case, like the experience of Zimbabwe, we had a lot of panic from the healthcare workers. And since we still had some of the Ebola suits available, the healthcare workers, once the Ebola suits were no more there, were feeling that they don't feel well protected when they just use the gowns. So we are currently working with them to improve the IPC behavior, and we are going to also use the lessons learned from the previous presentation that was done to enhance this area, because we are still having challenges of our healthcare workers adhering to use the appropriate PPE. We also need to strengthen proper practices to triage, and we are also going to establish easily identified and well-ventilated isolation facility and separate rooms from other services, because from the KPI scorecard assessment that was conducted, we realized that some of the identified isolation facilities within some of our hospitals didn't meet this requirements. And we are going to continue to do the training of IPC focal points within the health sector for the remaining facilities. And with the support of Africa CDC, we have identified IPC focal points, which are yet to be trained with the support of Africa CDC. And these are the partners that have been supporting us on IPC and WASH activities in the country. And apart from this, we have also received donations from other countries, like from JECMA, the government of Egypt, and other countries. I thank you for your attention.
Thank you very much, Dr. Limpo. Thank you for everybody. We do have some questions and answers, and I'm going to go through them at the moment that's posted on there. And I'll ask the panelists to just try and assist with the questions that I've been asking. There was one, and I'm going to direct this to you, Sakai. They said, thank you for the lovely presentation. They just wanted to know, how did you establish a relationship between decreased immunity and asymptomatic transmission and COVID-19 infections amongst the healthcare workers that you've studied?
Okay, thank you for the question. And I think it has been established that people who have got lowered immunity due to other comorbidities like hypertension, like the asthmas, and any other chronic conditions, they have died high risk of getting COVID-19. So, and generally in our area, in our zone, most of these people, these healthcare workers, even though they were testing positive to PCR, they were generally they were asymptomatic. It's a very low percentage of healthcare workers who presented with mild symptoms of flu. So we ended up concluding that it was due to those comorbidities. We were also asking generally if these people had comorbidities, and we realized that most of them, especially those who were above in their 40s, they had especially hypertension. They make up a larger number of those who presented with who tested positive, and they were also asymptomatic. So that's how we ended up also relating the lowered immunity to asymptomatic transmission. Thank you.
Thank you, Sakai. The next question, I want to put it out there to maybe Africa CDC or Prof. Shadai. They wanted to know that viruses are functionless without living hosts. So what makes COVID-19 viable on the object's surface? Thank you. Prof. Shadai or Karen?
Sorry, I was trying. I'm in a bit of a noisy place. I'm in the airport. Thank you very much. I thought that was an interesting question. Yes, they're not viable in the sense that they won't multiply or do anything like that. But if they are transferred from the surface to the, and they still have their lipid coat, then if they infect, then they can infect if they're transferred from the surface to, and get access into the human body. Don't forget, but if their lipid coat has been destroyed, they're no longer viable. So the viability is not so much that they can be multiplying, but that they still have the ability to infect. But once they've lost their lipid coat, which is what we do when we disinfect and when we wash, part of that is that you get rid of that, then they're no longer infectious. And that's why when we say we find by PCR, we can identify the virus, it does not mean that identification is viability, that and that's still infect that lipid coat. It has not been destroyed. They are viable because if they get into the body, they can still infect. At least. So I think that that's a very simple explanation for what that means. Thank you.
Thank you, Prof. Shadai. The next one I'm going to also give to you, Sakai. They wanted to know how you explain how you implemented your surveillance and reporting system among healthcare workers.
Okay, for healthcare workers, when we got the initial cases, we started contact tracing all those who were contacts of the positive cases. So that's how we started our surveillance. We were looking at all those who were in contact with the initial cases. So, and we started reporting, and would record them, and we have got a department which is also doing the PCR for healthcare workers only. So by record, when someone is tested, we are keeping the registers there. That's how we are doing our surveillance and also our reporting. So we, at the end of each week, we doing our statistics, and we are doing our recordings, our registers. We compare our registers, and then we see the number of healthcare workers affected from that surveillance of mainly the contacts and those who are tested. That's how we are reporting our cases.
Thank you very much, Sakai. The next one I'm going to address to Izini or Dr. Wande. They wanted to know what is the infection rate of the COVID-19 in Africa as of today? Izini or Dr. Wande?
I'll let Izini answer that based on today's presentations. She probably has the best answer to that. So Izini, if you're still online. Otherwise, you can move to the next question. If she comes back online, she can answer.
Okay. So I don't see that she's answering. So let's go to the next question. And this one I'm going to give to Karen Bratney and ask if she can maybe address this for us. I wanted to know, what is the more preventative measure to COVID-19? Is it hand washing with soap or sanitizing with a sanitizer? Over to you, Karen.
Yes, can you hear me?
Yes.
Oh, good. My internet has been extremely cranky this morning. In terms of efficacy, we prefer soap and water for several reasons. Number one, it kills germs that alcohol-based hand rub does not. Specifically, Cryptosporidium, Cryptococcus, and norovirus. So in those situations where you might be exposed to other viruses on your hands, it would be preferable to use soap and water. On the other hand, we're well aware that in many, many, many parts of the world, there is no water. So alcohol-based hand rub, so long as it's at least 60% alcohol, is quite effective against COVID, but you mustn't use it when your hands are visibly dirty. You still need to use soap and water because the alcohol-based hand rub is not gonna be as effective. So to put it simply, for COVID itself, if that's the only thing that you've been exposed to, they're equivalent. But if in fact you are in a healthcare facility where there are many other bacteria and parasites and viruses, that's why we recommend soap and water.
Thank you very much, Karen. We appreciate that. The next one I'm going to ask the panel, anybody who wants to answer this. They want to explain how purchase of less PPE is a good behavior change in the wake of the active pandemic. Anybody to answer that? Maybe Mola or Silas?
All I can think of, Anna, is that perhaps it puts the emphasis on the other forms of IPC that we've talked about, including administrative and environmental controls, which in the long run are much more important than PPE. But
Yeah.
I'm just guessing.
Sorry, can you ask that question again? I missed it. Sorry,
I want to know, Sade, the purchasing of less PPE, is it a good behavior change in the wake of an active pandemic?
okay. I think it was in the context of what the lecture that was being given. And I think it is speaking to the fact that people were using the Tyvek suits, that's the Ebola suits. And a lot of governments were spending hordes and lots of money on that suit because healthcare workers just said they had to use it. And we all know that it is not necessary for most of what they were doing. So in that wise, when we got healthcare workers to change behavior, we actually spent less on PPE, but diverted them to that kind of PPE. Because let me also mention that when they're talking PPE, most at the beginning, they were all talking about the Tyvek suits. So they're not talking about masks. They meant that, that big white coverall. So there was a reduction in the amount of money that was being spent because the masks are cheaper. They were buying more masks and more, sorry, and they were getting more of that PPE, but spending less on the Tyvek. So I suspect that that's what was meant, because that's what we saw across many countries. That as they changed behavior, they moved to gowns and they moved to masks and got away from this very expensive item of PPE. Thank you.
Okay.
Hello, colleagues. This is Dr. Basim Zaid from WHO Regional Office for the Eastern Mediterranean. May also add some comments on this question as well?
Please go ahead.
Yeah, thank you. This is actually a very important question. And in addition to the comments and feedback from colleagues, I would also say that there should be a balance. There should be a balance between purchase of and availability of personal protective equipments and their use. There are few related issues. The first one is, and also colleagues have said that, personal protective equipments are essential component, but they are not all the components of infection prevention control. We need to look into them in a more comprehensive way. Personal protective equipments will not protect you as a healthcare worker, or will not stop the spread of any outbreak in healthcare settings, including COVID-19, if not used appropriately and rationally. This is number one. Number two, yes, healthcare workers, they need personal protective equipments. But again, as my colleagues explained, which types of personal protective equipments for which procedure and which medical procedure being done with the patient, using the appropriate is more important than just having personal protective equipment. So we need to have the appropriate personal protective equipment according to the task being performed with the patient. And as colleagues explained in the presentations, in most of the situations in the routine medical management and care of COVID-19 patients, we need personal protective equipments as part of the droplet precautions. So we need the medical/surgical, sometimes countries call them surgical as well, masks, in addition to gloves, goggles, and eye protection, and gowns. So the appropriateness is very important, as my colleague said. We don't need Tyvek, for example, or full coverall in healthcare facilities. So this is number two. Number three, also fitness for the task, and also rational use. And instead of like putting less money to personal protective equipment, let's focus more on let them be available, but also work with the administrators and management of the healthcare facility to rationalize their use and train and simulate, do simulation and exercises with healthcare workers so that they rationalize the use of personal protective equipments according to procedures and according to the tasks and according, of course, to the type of the healthcare facility and also the patient. There is a lot of rationalization of exercises that we can do to rationalize the use of personal protective equipment. Three, I would say, as I said in the beginning, other important IBC measures are also important, and we need also to make them available, like hand hygiene products, whether soap and water or and tissues to dry hands after cleaning with soap and water, or alcohol-based hand drops available across all the areas of the healthcare settings. Issues also for respiratory hygiene. We need to make sure that tissues are available, masks are available for patients with respiratory symptoms as well. So it's this balance that we need to achieve between availability and rational versus unnecessary use of personal protective equipment. These are my quick comments. Thank you. Over.
Thank you very much, Dr. Syed. The next one I want to put to Sakai again. They just wanted to see how did you measure behavior change? Over to you, Sakai.
All right, thank you, Anna. Behavior change, it can be measured by self-view or others' view. So in this case, it was we were asking people questions to evaluate their own behavior from what was happening from the beginning of the pandemic, from the beginning of these infections in our institutions, to even when the cases were still ongoing and post the interventions and seeing the reduction in the cases. We were asking the healthcare workers what they think about what was implemented and what has been the outcomes, and people were happy about the IPC measures that were implemented and what was really happening, the changes that those measures were bringing into our institution. So we would say the views of the implementers, the positive feedback that they were giving us on how we were implementing and also their performance and just the reduction in the number of cases and our general IPC practices. We're using that to measure the change. And we also made use of tools to the hand hygiene tool that I mentioned that we used. Using that higher hand hygiene tool also helped us to measure the behavior change that was amongst the healthcare workers. Thank you.
Thank you, Sakai. The next one, I also wanted to know, how do you separate the contacts and the confirmed cases in one ward?
Oh, okay. This ward, it consists of base and side wards. So at a time where we have never had more than 4 cases at a time, we suspected cases. So we are putting a patient in a bay, very far away from each other to try and minimize the infection. We are putting a patient in a bay. And then when the results come, then that's when we are moving now a patient to a side ward, awaiting transfer to our neighboring hospital, which has been designated as a COVID center. So we are just making use of bays in that ward and the side wards. Thank you.
Thank you. The next one that they've asked, I'm going to open up to the panel. Anybody can respond. They would like to know what would be the most likely remedies for health practitioners in local health village centers without proper assistance if the health equipment, I'm not sure what they mean by that, and they tested positive and facing stigma in the society. So it seems like they want to know what is the best remedies for healthcare professionals in the local village centers. How would they go ahead if they are tested positive and facing stigma for the workers? Anybody to have an idea?
This is Basim here from EMRO, W.H.O. EMRO. Could you please repeat the question? Sorry, it wasn't clear.
No, it's fine. Let me just read it like they put it. It is a bit unclear. They said, what would be the most likely remedies for health practitioners in local health village centers without proper assistance if health equipment yet they have tested positive and facing stigma in the society? So it's a bit unclear what they would like to know. So Tony, if you can maybe just clear up what you really want to know with this question, and then we can re-ask that. So I'm going to just park. Here's one as well for the panel. She wanted to ask the tool to share to assess isolation centers. Anybody that's got a tool that we can maybe share with them for the assessment of an isolation center? I know there's one on the Africa CDC website, so I'm sure if they go there, they would be able to find the tool to assess isolation centers if they are in fact safe to be used or properly set up. Is in your one day, if you've got anything else?
Yeah, so I think I can, that I'm going to put the link of that document, just a guide. It has a mini sort of checklist that can give you guidance on how your isolation centers should be. I will share that on the chat, and I will reply directly to Chris. I can see the question, so I'll send that shortly.
All right, thank you. Then there's one that wanted to know, how do those IPC scores in health facilities all Lesotho are evolving now? Only one center has 81%, there's a big problem. So Marcus, I'm not sure what you are asking, except for the IPC scores in the health facilities or Lesotho that are evolving. So Dr. Limpo, I don't know if you have got any answers to this question that they were asking about the IPC scores in health facilities or in Lesotho evolving cases happening.
I didn't get the question clearly.
They were asking, how do these IPC scores in health facilities or Lesotho are evolving? They want to see it's a big problem, so.
I think they mean, is it improving? Has there been any more measuring or monitoring since the data that she presented, which looked to me like it was pretty recent?
The assessment was done in August to first week of September, but we actually did a feedback session to the National Referral Hospital, and the assessment that was done, they had improved from 81% to 92%. Currently, as I mentioned, we had challenges to give the feedback to the other facilities. So our team is out in the field giving the feedback, and we were also hoping, after training the district IPC focal persons, for them to do the second evaluation. But from the feedback that they had, they've been giving out when in the field, when they're giving the feedback sessions, for some of the IPC thematic areas, they have already seen some improvement. Thank you.
Thank you, Dr. Limpo. The next one, they wanted to know, how might these lessons learned about IPC behavior changed at the hospital level translate to primary health centers? What behavior change practices should be prioritized at primary health centers? So I think this is open to either Sakai or anybody from the team on the panel.
This is Basim here from EMRO again. I can start, and maybe if some colleagues wanted to have further comments. Actually, I would strongly advocate for standard precautions, elements of standard precautions to to be promoted at primary health care. This would help not only for COVID-19, but any other issues. Infection prevention and control actually is not centered around a specific disease or a specific outbreak or pandemic. It's a set or group of measures that we need to apply for all patients all the times in all healthcare facilities. Because in most of the cases, we don't know um, the patients or the families or visitors coming to us, coming to the healthcare facility. We don't know what do they have and what are their complaints and whether this is infectious or not. So I would say standard precautions, element of standard precautions. Of course, at the time of outbreaks or pandemics, we need probably to prioritize. Talking specifically about COVID-19, we need to prioritize, of course, standard precaution elements like hand hygiene, like respiratory etiquette and cough etiquette, and respiratory hygiene. We need also to prioritize use of personal protective equipments at primary health care. Many guidelines now advocate for universal masking or wearing medical/surgical masks in healthcare facilities in areas where community transmission is evident. And there are many countries in our regions that have this feature, that have community-wide transmission. So again, masking or universal masking is part of personal protective equipments. And of course, adding additional personal protective equipments based on risk assessment. So these are some of the elements of standard precautions that we need to promote more and more in healthcare facilities, especially the primary healthcare. Of course, we don't say to neglect others like injection safety, like management of medical wastes, like environmental cleaning, and also cleaning, disinfection, and or sterilization of medical equipments between patients. These are also still very important elements of that we need to also not to forget in primary health care as well. Over to you.
Thank you, Dr. Zayed. Anybody else
May
wants to?
I add that in
Sorry.
primary healthcare centers, I think we've tried to emphasize this in the past, and I know it remains a problem in many facilities based on the ICANN monitoring projects happening. The issue of triage outdoors and decompressing waiting areas, making crowding less of a problem, is key both to cut down on COVID transmission, but also to cut down on transmission of many other infectious agents. And I would say that the looking forward, hospital redesigns and PHC, primary health center redesigns would be key, because no matter what the next infectious agent is, crowding in indoor waiting spaces will remain dangerous in terms of nosocomial transmission.
Thank you very much, Corin. We don't have any other questions at the moment. There's one that it just said no outbreaks. I'm not sure what they meant. I don't have anything else at the moment for any of the questions. I know there's one or two people that raise their hands, but it's very difficult to answer raised hands. So if we can rather type the question in the Q&A box, then we can address that. But other than that, I want to just thank everybody for their participation, and just want to remind you that we will have our week 6, the final one in this series 5 next week. There's also the French session happening on Friday at 1 o'clock East Africa time. So if we can, if the French speaking people can advocate that as well, and then next week we'll close this series, and then we will have 1 week break and then start with the series 6. We will also have some discussions. So if you do have any topics that you want us to discuss, please send it to us so that we can address some of those questions in our different weeks. And if there's anything else that you want to need, you can contact either Africa CDC or ICANN, and we can see how we can address it from there. Thank you very much for our panelists. Thank you for our speakers. Thank you for your time, and we hope to see all of you next week. Thank you. Goodbye.
Thank you. Bye.